All right, guys, what's up? I'm gonna do my best to summarize the lecture that we would have on Wednesday. We're gonna pick up where we left off. We talked about red blood cells. We talked about blood typing, kind of what red blood cells do, what they have in them, and how they go about their daily business. And now we get to the conversation of leukocytes, which are white blood cells. We talk about them briefly in this section of blood, and then we dive into the lymphatic system, and then obviously the immune system in the next section. So leukocytes, or white blood cells in general, are broken into two categories, depending on if they have little speckle things in them called granules. So we have granulocytes, which we can kind of see here. And we have agranulocytes, which we could see here. Before we even do that, we should mention that we have two types of stem cells that kind of branch off the blood stem cell. We have myeloid stem cells, which will turn into red blood cells, platelets, and the granulocytes. And then we have lymphoid stem cells that will turn into all your lymph stuff, right? B lymphocytes, T lymphocytes, natural killer cells. So we're done with the red blood cells. We're done. Well, we'll talk about platelets in a little bit. And right here, we're just talking about the two different types of leukocytes or white blood cells. So our granulocytes are neutrophils, eosinophils, and basophils. Um, they are granulocytes because they have visible speckles in them. They have granules in them, and these contain various proteins and things. And the agranulocytes do not have granules, hence agranulocytes, right? They're nuclei in AMP2. You'll do like different shaped nuclei and things. But the major lymphocytes that we talk about are B cells, T cells, natural killer cells, and monocytes, which I kind of drew that thing. Whatever. Drew this thing wrong. Should be that. And then that would look like that. My bad. Because monocytes don't have granules, right? And they're the largest ones, and they have two different subcategories, kind of. And we'll show this on a different slide, but their two different subcategories are macrophages and dendritic cells. These guys are very good at strolling around and phagocyzing things and eating up bacteria and a bunch of other stuff that we will talk about. So just to kind of give a general summary of what these granulocytes do, obviously in the immune system, we're going to talk about this in a little bit of detail. But just kind of introduce it. Neutrophils are the most abundant. That is important, right? At least 60% of your white blood cells are neutrophils. They are usually, because of their number, the first responders to any type of infection site. And they're pretty good at doing phagocytosis, which we've talked about at the beginning of the semester. But basically, these white blood cells can come over, and we'll look at the process probably in the next section, and engulf bacteria via specific mechanisms. Eosinophils, low percentage. Basophils, even lower percentage, right? Eosinophils traditionally are responsible for, attacking parasites, as well as involved in allergic reactions. We'll talk about a couple parasites in the next section. And we also see basophils respond via histamine to allergic reactions as well. And we'll talk about what heparin is and what its role is in blood clotting and things like that. So three different types of granulocytes, from most abundant to least abundant, and in general, kind of what they do. I'll underline that because that's cool. Are agranulocytes, the not granular guys. Even though it looks like it in these pictures, they don't have granules. You can see much more pronounced granules over here. These are just the nuclei and how they stained. So our lymphocytes and monocytes are two subcategories of agranulocyte. The B cells are very important, and we will talk about them a lot because they are responsible for producing antibodies. Antibodies are a protein that's specifically designed to attach to something. And we'll go through the whole process probably on Monday. T cells help regulate immune response. They kill infected cells. And we'll kind of talk about how they go about doing such things. And then you have natural killer cells that can destroy virally infected cells, cancer cells, things like that. Friendly cells that have just been contaminated with something like a virus or some type of cancer-like behavior. And again, we'll discuss that in the immune system. Monocytes, as stated, are the largest. And the two different types we have are macrophages and dendritic cells, right? And I said they perform phagocytosis, and they can help kind of present antigens, if you will, to other immune cells. So they kind of help in the whole immune cascade. This is, if this works for you, totally cool. This is in order from most to least. Never let monkeys eat bananas, 63631. And it just goes in the order of neutrophils, lymphocytes, monocytes, eosinophils, and basophils, clearly being the lowest number. There are two different issues we can have with leukocytes. Normally, you can see here your white blood cells are far outnumbered by red blood cells. Even just looking at this simple stain, we can see a white blood cell over here, over here, over here, and one over here. And you can see a lot more red blood cells, right? So 700 to 1, sure. We want those white blood cells to be less concentrated. And during times of infection, obviously these numbers will go up, or some other types of conditions we'll talk about, like leukocytosis. In the case of leukocytosis, you have extremely high elevated numbers of white blood cells. Normally, these numbers range-ish from 5 to 10,000 or 5 to 12,000 cells per microliter. But what could cause elevated numbers of white blood cells? Everything, right? And it breaks it down. If you look each one of these slides, even though I'm going through it pretty quick, all of the sub notes underneath there. If you look at the presenter view or whatever, summarize and kind of highlight everything I'm talking about, right? And maybe even a little bit more detail. But obviously, infection, inflammation, stress, some bone marrow disorders we'll talk about, and leukopenia is when you have very, very low white blood cell numbers, serious infection, certain types of medication, nutritional deficiencies, which we'll talk about a few of them, radiation, right, or any type of destruction of bone marrow. Obviously, that's where these white blood cells are being produced, could result in lower numbers of white blood cells. Let's say you have an infection. One test that they could do is a differential white blood cell count, right? All they do, they take a sample of blood, they put it on this lovely graph thing, and you would literally count cells. So being that we know neutrophils are going to be the highest percentage and XYZ, we're supposed to have about this many, you would look and you could count how many white blood cells there are of a particular type. What this would tell you is potentially the cause of said infection. If you had high amounts of neutrophils, being that they kill bacteria, probably could be an indicator of bacterial infection, etc. And then obviously each of these counterparts has a low count. If you had high amounts of lymphocytes, perhaps some type of leukemia, infectious mononucleosis, which we'll talk about, viral infections, high amounts of monocytes, perhaps viral or fungal infections, etc. Eosinophils, some type of allergic reaction, as is basophils. And you don't have to memorize every single thing, but just kind of understanding what a differential white blood cell count is. And then obviously, as we go through each cell type, you're going to know what it kills. So leukemia specifically is red bone marrow cancer. We've talked about bone marrow many different times. This is what normal blood looks like. We could see a white blood cell scattered here and there. And in the case of leukemia, we could see that there are a absolute tremendous amount of white blood cells, right? So think of it kind of as almost cancer of your leukocytes, where you have an excessive production of not a skin cell like in skin cancer or whatever. In this situation, it's leukocytes, right? So because the bone marrow is so busy over producing a lot of these white blood cells, the red blood cells, white blood cells, and platelets will suffer, right? So obviously, if you're along with elevated numbers of white blood cells, um, you'll often see decreased amounts of red blood cells, etc. So we would have difficulty transporting oxygen, difficulty clotting blood. Platelets are a component of that. Um, and we're not making as much of the other types of white blood cells, so perhaps they wouldn't be able to fight off infections that they're supposed to fight off as well. Obviously, these white blood cells will enter the blood, and there's a lot of them, so they could spread to lymph nodes and cause enlargements, usually. And I don't know if there's a picture on here, but you'll see a picture of enlarged, lymph nodes in the cervical region and a variety of other areas. And there are four basic types um, based off of acute or chronic. Acute means it's aggressive, fast growing, and comes on pretty quick, right? Acute means short. And chronic means it's usually long term, kind of prolonged, or it's been accumulating over time. And then the only other difference is what type of cells they affect. Are they lymphoblastic cells or are they myeloid cells? So if you remember back, um, and a lot of these you're going to see in older individuals, older adults, and stuff like that. With the ALL being the most common in younger children. Um, but if you remember back when we had that kind of breakdown where we had the myeloid and the lymphatic or the lymphocyte branch, that's all it's differentiating from. So whichever one it originates from, and then if it's acute or chronic, and that's your breakdown of the four different types of leukemias. Obviously, different cells will be multiplying like super crazy. Good. We've talked about white blood cells. The next thing we have to talk about is hemostasis. So we'll talk a little bit about platelets, and obviously that was an introduction for white blood cells, so we can cover it. The whole next PowerPoint is literally about the lymph and immune system. Um, so if you get a blood vessel injury, and we kind of talked about this a little bit when we did the skin, but if you get a blood vessel injury, and I noticed this before when I was looking at it, this should say step 2, and it doesn't. Um, you have a series of events that are responsible for kind of sealing up that hole, right? And we'll talk about that over the next couple slides. To make sure that you don't lose lots of blood, and we have the formation of a blood clot, and platelets are involved in this, etc. So how we stop bleeding, number one, vascular spasm is immediate, right? Right as soon as this happens, you kind of have some quick vasoconstriction, um, and it will, in theory, reduce the amount of blood that comes out. Shortly after, you have step 2, and I'll try to color code these for you. We have, because of the damaged tissue, we have exposed collagen fibers. So simply put, we form a platelet plug, right? And we talk about that coming up. That platelet plug, so platelets are your little fragmented, they're responsible for blood clotting. They're fragmented cells. And number 3, we have coagulation. And I should make sure I pick a different color. And this pretty much simplifies it. We're going to go into some crazy detail with like clotting factors and stuff, which I don't expect you to memorize. But the coagulation is the blood clotting process. So we're kind of turning this liquid blood into a gel. and that gel forms the blood clot, right? So we'll mention like what fibrin is and stuff like that. And basically you have kind of this mesh forming to kind of seal up that hole via cascade. Um, and cells start to stick to it and stuff like that. And that is the blood clot, right? So you can see here, red and white blood cells get trapped, and the blood clot is formed. And basically, we seal that up. Once the blood vessel or the endothelial tissue heals, then we want to dissolve that clot, and that's basically what the next couple slides are. I'm going to mention this, but I'm going to tell you kind of what you have to focus on. There's an extrinsic pathway, which occurs more rapidly, which happens outside the blood vessel. That's what extrinsic means. And then there's an intrinsic pathway, which happens, it's slower, it's more complicated because you really want to make sure that you're not accidentally clotting blood all the time. So there's a lot of checks and balances as we go through here, and I try to describe this to you. Um, there's a lot of checks and balances to make sure you don't accidentally clot blood, because that would be really bad. Um, so what we have are thrombocytes. The things that were facilitating that whole previous slide are platelets. A platelet is a thrombocyte, right? They are fragmented cells, fragmented um, big cells, if you will. And there are a lot of platelets, right? They don't last very long. If you remember, the red blood cells had a tendency to last for 120 days. White blood cells can last for a very long time as well. And they just circulate through the blood, man. They just float around, right? You can see platelets over here, and you can see this kind of injury site where collagen fibers are exposed, and then those platelets start to adhere, right? And that's kind of the formation of that platelet plug. Makes sense. Um, so we do store extras. We'll talk about the spleen in a little bit. Um, and this is what we talked about, platelet plug formation, right? They adhere to damaged blood vessels. They release chemicals that call in their friends. That's what release chemicals that activate other platelets means. So basically they aggregate like you can see in that picture. I'll color code that for you. And they form the platelet plug. In the process, they release certain factors, some of which help tissue repair, right? And that's why some platelet therapy is used to help repair certain types of tissues, depending on what injuries you have. Sometimes they extract these and inject it and stuff like that. I think we talked about that when we talked about joints, maybe, and ligament damage. You don't have to memorize this pathway. All this is saying is, if you recall, we had a intrinsic pathway and an extrinsic pathway. You could see there's less steps in the extrinsic. You could see that there's more steps in the intrinsic, right? The extrinsic pathway is dealing with this process outside of the blood vessel, and the intrinsic pathway deals with it inside. Either way, we have something called thrombin. Let me use a different color here because why not? We have something called thrombin. Thrombin converts fibrinogen into fibrin. That's what this is showing, right? So fibrin is what starts to form kind of it's protein, right? It helps form kind of the scab, if you will. It's kind of causes that adherence, and then that's what stuff sticks to. And that is the glue for the blood clot. So you don't have to memorize factor 12A and 11 and all this stuff. But they both result in basically the same process of converting prothrombin to thrombin, and then thrombin converts fibrinogen into fibrin, and that's the basis, if you will, of the sticky component of the blood clot. How do we control blood clotting? Like I said, you don't really want to mess it up. You have localized clotting, right? So they are these factors that we just showed on that previous slide that you don't have to memorize, um, work locally, right? They're not released systemically. They're not causing clotting all over the body. The platelets adhere locally to that collagen that is exposed, and it is limited to that damaged area. So number one, we don't want clotting to happen everywhere, right? So there's a localized control based off of those two factors. We also have the ability to remove clots, right? There is something called plasminogen and plasmin that after that clot is formed and the tissue's healed, they digest, they break down, they literally get rid of the fibrin thing that we just talked about, right? Those fibrin protein threads, and they get rid of it. So they can dissolve the clot, which is awesome, right? Because you don't want that blood vessel to stay blocked. We want blood flow to resume as normal. So we have a localized control. We have an ability to remove blood clots. We have another ability to prevent excess clotting. Um, we have heparin and things like that in our body that are basically anti-clotting factors. So we make certain chemicals that can prevent clots, right? And we'll talk about heparin as far as treatment options and things like that as well. And there's a negative feedback regulation. Once enough thrombin is formed, your clot slows down because the production of that thrombin activates anticoagulant things, chemicals, pathways. Um, so basically, we have a couple different checks and balances, if you will, to prevent excessive clots and to make sure when clots do form, that they can be removed pretty efficiently, right? So there's just a lot of chemicals that are kind of checking and balancing each other to make sure nothing super bad happens. But we've mentioned a thrombus before. You can have a blood clot form in undamaged blood vessels, right? Most of the time, it'll be dissolved. It forms. It'll be dissolved. It goes away. It's no problem. Didn't even notice anything. The problem becomes, which we talked about previously with pulmonary embolism, right? Which you should still know, is because it says it right here. When that random clot dislodges, right? And you have this floating mass of blood clot called an embolism. We followed the pathway as it came back up to the lungs and got stuck in a pulmonary artery, leading to hypoxemia and shock, sudden death, etc. No good. Obviously, this could happen in a cerebral artery as well, leading to ischemic strokes, right? So embolisms are no good. There are certain scenarios where we would have to administer anticoagulating drugs, right? They're injectable. There's a bunch of different names. They're used for prevention of deep vein thrombosis, which we talked about in the vascular chapter. They would be used if detected early enough to dissolve pulmonary embolisms. They're also used in individuals with limited mobility, right? Because when you're not moving, that blood has a tendency to slow down, right? There's not a lot of cardiac output. The blood's moving slower, and the chance of blood clots increases. Some common ones that we see are heparins, and there's different names and stuff like that. You don't have to memorize names. And synthetic clotting inhibitors. But they're all going to act on some component of that clotting pathway, right? To decrease the likelihood of blood clot formation. And I'm pretty sure everybody may have heard of before baby aspirin. A lot of people take it. It's very low dose aspirin. It will reduce the risk of heart attacks and strokes due to its blood thinning properties. But it is important, right? So we're reducing clot formation. It is important to see who would benefit from such a thing, right? It is a secondary prevention for people who've already had some type of cardiac or vascular issue, right? If you've had a heart attack and you had coronary artery bypass graft, or if you had a stent or an angioplasty or whatever, that could be beneficial. So for those individuals, that would be recommended. Um, Usually, primary prevention's not recommended, right? If you don't have any risk, if there's nothing wrong, you have no history of heart disease, um, it is usually recommended that you do not have to take this because you are not more susceptible to it, which makes sense. We're almost done with this section here. We have hemophilia, which is a genetic issue. So it's inherited, right? And you have a deficiency of clotting. There are different types depending on which factor. There's an A and a B. You don't have to stress about it too much. But clearly, it is more common in males. It is linked to the X chromosome, and females have two X's, and males have one X and one Y. So basically, if you have a female and she's got one of these things that's bad, if you will, um, the variation, she still has another one that's functioning normally and she doesn't have the disease. If you have a male and his X is bad, he doesn't have another one. So he has hemophilia, right? Clearly, this is passed down from genetic lineage. Severities are very different. Um, and there's some treatment options such as blood transfusions, I should say plasma transfusions, administration of clotting factors as opposed to anti-clotting factors. And there's a drug, desmopressin, that boosts levels of these clotting factors. So hemophilia, you start bleeding and you can't stop, right? Normal blood clotting, blood vessel seals up via all the mechanisms we just talked about. In hemophilia, you keep bleeding, right? And there's some symptoms here that you could see, easy bruising, etc. And lastly, um, different than hemophilia, similar in what could happen, but in hemophilia, that's a genetic disorder. And in this situation, it's a nutritional deficiency. So vitamin K deficiencies, vitamin K is involved in a variety of synthesizing clotting factors, right? We need vitamin K. It's a step to produce some of these factors. So if you don't have enough vitamin K, you can't produce some of those Roman numerals, and you're going to have difficulty or inability to clot blood, right? So you can have uncontrolled bleeding, very, very similar to some of the symptoms that we just saw. And obviously, if you take vitamin K, then you'll be good, right? So that's a nutritional deficiency leading to very similar symptoms to hemophilia, but hemophilia is a genetic condition. Cool. I'm going to try to make it through a little bit more of the next one. I am terribly sorry for my voice. I hope you can understand it. And this is our last lecture. Not going to be able to get through the whole thing, but I will get through some of it. And whatever I do not get through, obviously, I will finish on Monday to the best of my ability. And then you have your fifth exam on Wednesday. We talked about blood vessels. Know all the different types of blood vessels, pressures, etc. We talked about blood. We talked about red blood cells in general and how they do what they do. We talked about white blood cells and a couple different types, which we're going to see in this lecture as well, and kind of what they kill. But that was pretty basic. And then we talked about platelets and how they clot blood and form platelet plugs and thrombin and whatever. The lymphatic system is an entire system, we'll call it, they're not green, of green vessels that are not blood vessels that basically cover the body. Lymphatic vessels transport something called lymph. It serves many different purposes, one of which is fluid balance, draining the excess fluid. If you remember when we talked about blood coming in and blood coming out of capillaries, there was a 10-9 ratio. There was a little bit of fluid, a little bit more fluid coming in than leaving, right, in the blood vessel. So that extra fluid kind of gets removed via the lymphatic system. The lymphatic system is also responsible for removing old cells, damaged tissue, kind of keeping everything clean. It's also responsible for absorption and transport of dietary fats. When you eat fats, we can't just dump them into the blood. When they get absorbed, they get taken in through the lymphatic system through specific structures that we will discuss called lacteals. We have the production of B and T cells, which is our specific immunity, and we have adaptive immune response. So we will talk about what all these are, but in general, there's a few components of the lymphatic system. On this slide in particular, if you look at it, maybe I'll just show you. Oh no, oh dear, I messed that up. Yeah, I guess I have to do this. You can see on here, it literally simplifies everything, right? Lymph, what is it? Lymph vessels, bone marrow. We've talked about a lot of this stuff, but it kind of gives you a nice little summary. Now I'm gonna have to do this again. But in general, we'll highlight where these structures are. You saw some of them in lab as well. You have tonsils, right? You have a thymus. The thymus is located kind of right above your heart, kind of by your sternum. And we'll talk about what it does, but basically it matures T cells, it shrinks, it atrophies with age once you kind of have a pretty solid immune system. We have a spleen, which we will discuss and how it works. You have an appendix, you have bone marrow, not only in your hip, but in lots of bones. You have vessels, which are not just there, they're literally all those green lines scattered throughout the body. And you have lymph nodes, which are concentrations, usually by body openings. And we'll also discuss that, where we kind of accumulate lots of different types of white blood cells to kind of check stuff as it's flowing through. Same thing with the spleen. We have Peyer's patches, which are found in the digestive system. So within the intestines, we have some immune function and recognition. And then we have the cisterna chelae, which is basically an area where all of this lymph from the lower body comes up and meets. You have a thoracic duct, which transports all that lymph from the lower body. And you have a right lymphatic duct that transports some stuff from your right side, kind of just that top quadrant. And we'll see what a picture looks like. Oh, it's right here. The area drained from that right lymphatic duct as opposed to the area drained of the thoracic duct. So basically we have two generalized areas that are dumping lymph back into our venous circulation. Maybe the next slide will show it. I don't remember. So we have two primary lymphoid tissues. And the primary lymphoid tissue is where lymphocytes are created and mature. We call that immunocompetent. We basically educate them. It's like lymphocyte school, if you will. So B cells become smart or immunocompetent in bone marrow. B. T cells become educated in the thymus. And we'll see a slide on that in a minute. Secondary lymphoid tissues are where lymphocytes become activated and their immune response is triggered. These would be areas you can think of where they congregate post-school and check for bad things that are coming through, right? Where would that be? The spleen, lymph nodes, tonsils, right? Different types of mucus-associated areas. But these you can think of as checkpoints where they kind of hang out and they just wait for something bad to come through. And we'll Talk a little bit about that as we move on. The thymus is a site of T cell maturation. The end. A lymph node is looks simple, right? We see a picture of it over here. Um, right off the bat, it has a specific design, right? Lymph is not flowing super fast. Lymph is like pretty slow. Um, so lymph can only flow in one direction. It's very important. You don't want it going backwards. You'll have serious edema and swelling, and we'll look at two conditions that where that happens. So our afferent vessels are vessels that come in. We have more afferent vessels. You can see there we have three, and they're smaller, right? So they're just collecting lymph from all over the body, if you will. In here, we have B and T cells, right? Those are our lymphocytes. Those are literally, that's why they're in the lymph. Just chilling. They're just waiting as this stuff passes through here. They scan it, make sure everything's good. And then you can see here leaving, we have an efferent vessel, right? And there's an important component. You can see here this thing looks like a valve. It's because it is, right? Our lymph vessels have valves. I think we'll see that coming up. But the efferent vessel is going to be a little bit wider. A lot of stuff comes in, one thing goes out. What does that do? It slows down the lymph kind of in that area as it passes through and allows it to be scanned, if you will. We have lymph nodes all over the body. We have a lot of them, right? They're in different areas. We've talked about cervical. We've talked about inguinal. We have some in the pelvis. We have some in the lumbar region. We have some by the axilla, right? By the armpit, that's open. And we also consider some of these bigger organs. I think we'll see the mammary gland coming up, like the thoracic duct, thymus, spleen. Also harbor lots of lymphocytes. So, move that out of the way there. This deals, it looks like a decently complicated picture, but it's not that bad in theory. Lymph vessels drain excess fluid that comes out of your capillary. That's what this picture is showing. So we saw the arterial blood flow come in, right? Slows down. Stuff starts leaking out. Stuff starts getting pulled back in. And we have basically a net pressure that's more or less equal as it leaves. But we did have a little bit of water hanging out there. And we want to make sure that that excess water does not accumulate, right? That would cause edema and swelling and a bunch of other issues. So what we have are these lymph vessels. I'm sorry if I'm writing the same color and you can't see it, that drain out this excess water, right? It's going to pass through, obviously in lymph, not necessarily water, but it does allow us to drain that through. They have valves, which you can see here, which prevent the backflow of that, prevent it from going backwards. And obviously this would drain from the lower body. This would drain from the upper body, and it all gets dumped back into venous circulation. So that's all this is showing, right? You have little lymphatic capillaries that allow for draining of that excess water in your capillary beds. This just shows you the order. I'll do it in red because it's easier to see. How the right lymphatic duct and the thoracic duct dump blood back into our subclavian veins. Right there. We have the tissue that I just showed you. We have those lymphatic capillaries. We have those lymph vessels. So basically, these are getting bigger and bigger and bigger as we move up to a lymphatic duct. And in our situation, it is the thoracic duct, right? Uh, so blood vessel, or I should say lymph just moves here and then again dumps back into the vein. So you don't got to stress about it too much. Those capillaries drain the lymph, the water goes through a lymph vessel to a lymph node to a trunk in some situations, and into a duct, and then it just dumps it back into the vein. How does the lymph move? Slowly, right? Not super fast. It's not under high pressure like we have in arterial blood flow. We have two similar mechanisms. We have a respiratory pump, which we talked about with blood flow, and we have a skeletal muscle pump. The respiratory pump, when you breathe, the diaphragm kind of creates that pressurized vacuum and it helps suck lymph back up through that thoracic duct. In the case of skeletal muscle pump, when we move, we contract muscles. Muscles and lymph vessels often run kind of like by arteries and stuff. Um, when we contract those muscles, it pushes the lymph up. It can't go back down because it has valves. Pushes it up, can't go back down. So it's slowly kind of aiding in the inching of that lymph back to our thoracic duct and then back into the subclavian vein. Very similar to blood. I think there's a video. You should totally check it out. Talks about the drainage of lymph, and it probably summarizes it probably more clear than I can right now. We're going to see two conditions. We have lymphedema and elephantitis. Basically, as you can see, damaged or blocked blood vessels can lead to an abnormal accumulation of lymph fluid. If the goal was to drain all that excessive water, and that got blocked, if your shower drain is blocked, you're going to have a buildup of water. There's nowhere else for it to go except in this tissue, right? So basically what you have is the accumulation of a lot of this excess extracellular water, if you will. And it causes lymphedema, right? You have extreme edema because there's an issue with the lymph, right? There's a couple causes, and one of which is a parasite. You get this nasty parasite in your lymph or your lymph vessels in a lymph node, and it causes a problem, and it causes it causes a blockage, right, in your lymph. And you get elephantitis, right? You don't want the parasite, it's no good. And there's a little blurb at the bottom, you can read about it, but that's the gist of it. Parasitic infection, no good. There are things that can help circulate lymph in people that might be compromised in such a manner, like the lymphedema that we just discussed. So this device is designed to reduce the swelling and improve lymphatic drainage, enhance the mobility of this, basically connecting to the thoracic duct and boosting lymph flow for individuals with lymphedema, right? That's cool, right? It's pretty crazy. You would also probably see this in somebody who has congestive heart failure, because you would still have that fluid retention, and this would aid in that venous return, right? So if you could move venous blood, it'll suck some of that lymph in through the thoracic ducts, and it will continue to kind of create that vacuum-like effect, and keep your lymph moving. It's good. This one I'll mention, and I don't even know how far I'm along in this, but we'll try to finish the lymphatic system and maybe start off a little bit on the immune. We'll see. We have lacteals. So this is lymph tissue in the digestive system. Specifically, we usually talk about it in the small intestine. And the main point of this, right? These are little like little villi in your gut, in your small intestine. And their goal is to absorb things. So when you have foods like carbohydrates and peptides and things like fats, they need to get sucked up into here. Some of it will enter the blood, Some of it, like fat molecules, I'll do it in a different color here for you. Like fat molecules enter the lacteal. So the lacteal is just this horrible, horrible color choice. It's this green thing in here. It's lymph tissue, but it's specifically designed to suck up fats from the digestive system. So lacteals carry digestive, dietary fats into lymph vessels. Then they'll ship it to the blood eventually. It is a creamy white color, call it chile, because it contains fats, right? As all of this stuff gets sucked out of the digestive system, if you will, it goes to the structure we mentioned previously called the cisterna chile. That is the receiving point of all that stuff that's getting absorbed, sends it up to the thoracic duct, and you're good to go. Same pathway we saw before. We have the spleen. We don't talk about the spleen too much, but you have basically two parts to the spleen. You have red pulp and you have white pulp. The red is more oriented around blood, specifically filtration and storage and things like that. You can see kind of over here, all this stuff is red. Um, and then you have the white, which is our immune surveillance, right? Blood gets pushed through here, and we have lymphocytes and macrophages. Just think of it like a big lymph node, right? Where we can recognize and destroy pathogens and baddies that are coming through. Um, that's pretty much it. But the white part, the white pulp, is the immune component of it. We have lymphomas, which is cancer of the lymphatic system, right? Usually, I should say always, it's a type of blood cancer. It affects the lymphocytes, abnormal development, crazy mitosis, tons and tons of lymphocytes. And we can always tell this because of the enlarged lymph nodes, right? They're called lymph nodes because they contain lymphocytes. You could see kind of some cellular abnormalities, and there's two different types, and I'll try to keep it simple. I know people that have had both of these. We have Hodgkin's lymphoma and non-Hodgkin's lymphoma, right? And this kind of compares it, which type of cell, but it could arise for both B and T in both of them. Non-Hodgkin's primarily B, as opposed to Hodgkin's, usually B or T. So I'd probably be more T cells, but it doesn't matter. We see that one of them is more common in older adults, and we see that one of them is, I don't want to say more common, um, but it is common in younger individuals. Obviously, it talks about treatment options, chemotherapy, radiation, etc. Um, check it out. You don't have to memorize this entire thing. There's a nice little summary at the bottom of this slide as well. I think I'm reaching my end. This is just showing you how metastatic breast cancer can spread via the lymph nodes. We've talked about this before. You have your primary lesion, you have your lymph node location here in the axillary region, and you can have this metastasis and the spreading of those cells via the lymphatic system, right? So we have different stages of cancer and things like that, depending on how far those cells have spread. And the metastatic agent of that is the lymphatic system. I'll get through some of this. This is where we get into immunity. It's complicated. So far, we've talked about some types of white blood cells, blood clotting. We talked about lymph. What is a lymph vessel? What is a node? Couple diseases associated with lymph circulation, how it flows. And now we get into specific types of defense. There are a bajillion things trying to kill us all the time. There are bacteria everywhere. There are viruses everywhere. And a lot of the time, minus me right now, we're not always sick. So there are some crazy things going on that are killing off bacteria and viruses all the time. Speaking of which, we have two general categories of immunity. We have innate immunity and we have adaptive immunity. These are both designed to detect pathogens. A pathogen is anything bad that's trying to come in and get you sick, more or less, right? So we have some key things, right? Look at this is what I'm talking about. All types of things trying to destroy you at all times. The immune system's keeping you good. So we have lymphoid organs, which we'll talk about. We have leukocytes, antibodies, and cytokines. Um, I think we dive into a specific slide on innate immunity, so I don't want to talk about it too much. Um, but it's non-specific. Innate immunity is designed to just kill bacteria in general or prevent things from getting in or destroy viruses in general. And the adaptive immunity is specific, right? It's specifically targeted. We're going to talk about CD8 and CD4 cells, developing memory for something, how vaccine works, why you don't get the same sickness twice, more or less. And if you were to simplify it, antibody production. And we'll talk about cytotoxic T cells. Susceptibility makes sense. You can develop immunity, right? If you were exposed to something because you were infected, or you were immunized and you were exposed to a vaccine, in either of those situations, you've developed immunity, right? Your adaptive immune system has seen that, recognized it, killed it, and it keeps some memory cells around. So next time it sees it, it kills it super fast. That's what we call immunity, right? If you've never seen it, you are susceptible, hence part of that susceptible population. Susceptibility means vulnerability to the sickness. You do not have a resistance to the infection. Age, obviously, as we age, our immune system becomes more compromised, as well as health conditions and things like that, lifestyle, environmental factors. There's genetic components because there's genetic disorders, there's biological factors that are involved, and there's medical conditions. Just think like autoimmune diseases, things where your immune system's compromised or busy doing something else, things like HIV, etc. So obviously factors that increase or decrease susceptibility for sure. And there's a little blurb at the bottom that summarizes it pretty well. We have two lines of defense. We have a first and a second. And the first one is if things can't get in to your body, they can't get you sick. Pretty straightforward, right? So we have the first line. We have the first line of defense for innate immunity. Innate, you can kind of think of like you're born with it, and they're just normal things that happen in your body for a particular reason. So I'll summarize this. Maybe I'll do another slide and take a break. We'll see. We have physical components, chemical components, and biological components. The physical components are things that physically prevent stuff from getting inside. Our skin, if you can't get through the skin, you can't get in. Mucous membranes, if you get trapped in sticky goo, you can't get in. Hairs and cilia, if you get stuck and something's pushing you out because you're stuck in the mucus, right? Cilia and stuff like that with that beating wave-like contraction, eyelashes and eyelids, saliva, urination, etc. We also have chemical, a low pH, acid kills things. stomach acid, right? Sweat, vagina pH. These are all acidic and they can kill things. We will talk about a few, but we have antimicrobial enzymes that are produced throughout our body. Things that are chemicals that literally will poke a hole through a bacteria, disrupt its membrane, stop some crazy biological function that's going on. Um, so we have a bunch of chemical antimicrobial enzymes that are produced. Talk about a few. And we have our normal bacteria. If you have a habit or some type of place where something can live and you have normal bacteria living there, that space is taken, right? So another bacteria can't live there because something else is living there. Some of these healthy bacteria actually produce chemicals that destroy other potentially pathogenic bacteria. Um, so we have a normal microbiome, which is extremely important. And oftentimes when that normal biome's disrupted, it opens up a space for those bad guys to come in, set up shop, and you can get a pretty wicked bacterial infection. Um, we have specific second line of defense. Let's say something makes it through. It gets through the skin, it gets through your mucous membrane, it sneaks into the blood somehow. It's in your body. We got our second line of defense, right? We have cells that are just in general designed to kill certain things. One, we have phagocytes that go around and kill things. Right? They eat stuff. We have natural killer cells, which we'll talk about. We also have some chemicals, some proteins that are specifically produced in the body, not necessarily outside the body. And we'll discuss each one of them. What is an interferon, complement system, iron binding proteins, and antimicrobial proteins? And I'm judging I'm probably not going to do that right now. And it gets complicated, but as long as you know kind of what each one is, you'll be okay. You don't have to know 50,000 steps and stuff. And then we have other basic responses, right? Like inflammation and fever, right? These are when something gets inside. It doesn't matter if you have a fever, if something's sitting on the surface of your skin, right? But once these things get inside, we have an inflammatory process we'll discuss. And we also have a fever, obviously increasing core body temperature can denature bacterial proteins and things like that. Um, cool. Might do a few of these because I think I got some time. Um, all we're going to do is we're going to go through and we're going to talk about each one of these. Whenever you're confused, you just come back to the big picture. What am I talking about? I'm talking about antimicrobial proteins, right? Maybe I'll just do two. One of these proteins is called an interferon, right? Their main goal is to prevent viral replication. What a virus is this little dude that attaches to your cell. It basically injects a piece of DNA or RNA and it hijacks your cell. And now your cell becomes a virus producing factory. So what interferons do is they interfere with viral replication, right? They tell, hey, look at all these cells next to me, all my buddies, bro, right? Start destroying RNA, right? So that cell can kind of pause what it's doing. It's telling the cell next to it, like, yo, something bad's inside me. It's probably going to try to get inside you. Start destroying RNA. So when that virus injects itself into you, you're going to destroy it, right? Obviously, the virus is going to need to make proteins as well. But the destruction of that RNA is signaled by that chemical. It also can tell neighboring cells that are infected to undergo apoptosis, controlled cell death. You're infected. Stop the spread of the virus. You got to go. And it also can activate immune cells that would be involved in fighting viruses to kind of shut that down. Viruses are pretty sneaky. Interferons are one mechanism that we have to kind of try to combat that. This is confusing. There's one aspect of this that I like. This is called the complement system. Go back to the big picture. The complement system are antimicrobial proteins, right? There are different pathways. At one point in my life, I learned the intricacies of all of this. I don't expect you to. Um, there are a couple different pathways, one of which results in something I think is cool. It's called a MAC. That is a membrane attack complex. Basically, what it does is it is a series of proteins that pokes a hole, basically makes like a Mario pipe, right? It pokes a hole in the membrane of a bacteria. That's one aspect of complement activation. It can also increase inflammation, and it can also trigger phagocytosis. It's proteins, right? It's a series of things that can result in either lysis or phagocytosis or inflammation response. Um, but the complement system, I think for all of these, the big picture is what's summarized at the top. I'm not going to ask you about C3b, C3a proteins and blah, blah, blah. That's a class called immunology. You don't have to take that right now. Bacteria, specifically, this relates to the gut, but bacteria need iron. We have iron. Sometimes we have a lot of iron. So one thing that we have, which is kind of like a backwards way to prevent bacterial growth, I guess, we have iron binding proteins, right? What they do is they bind up iron. So the bacteria doesn't have all of this available iron to grow, right? One that we talk about is ferritin in the liver. I think I mentioned that last lecture. I don't remember. That can bind iron and help us recycle red blood cell components and things like that. Hemoglobin has iron, transferrin, lactoferrin, whatever. Basically, by having these iron binding proteins, it limits the amount of iron that's available to these bacteria, right, that are pathogenic and could grow way out of control if they had access to all of it. And I'll do this one and I'll wrap that up. We have antimicrobial proteins, AMPs. They are literally chemicals, proteins, small peptide chains that go into a membrane of a bacteria. If this is your bacteria, this thing jams itself into there. It causes lysis, right? So there are specialized proteins that are capable of literally injecting themselves, if you will, it's not really the right word, incorporating themselves into a membrane, and that triggers that bacteria to lyse. These are antimicrobial proteins. And then we'll get into phagocytosis, but I'm going to stop because I can barely talk. Whatever. Thanks for checking it out. We will finish up the rest of this PowerPoint on Monday. Get your quizzes done, get your study guides done, and enjoy your weekend.